Hi everyone, my name is Melanie Grant, and this is C&M Glass. Today we're covering for our CPT course on male reproductive, female reproductive, and maternity-based coding. Our key points to look at are the organization of the male and female reproductive systems and some focus on maternity guidelines, definitions with antepartum, postpartum, and abortions, and differences in codes for vaginal and cesarean deliveries. So let's get started. Before we look over here at some of our definitions, I wanted to go into the CPT Codebook with you to look at some of the organization and some of the details that you'll see in these sections. I'm looking at the 2018 AMA Professional Edition CPT Codebook that's recommended for this class. You may have a different version of this book, and if you do, that's okay. I, in this book, am on page 359, looking at the male genital section. You'll notice that this falls right after the urinary section, which we talked about last week. And in fact, I've put up a few videos that cover the urinary and male reproductive systems together, as I felt that they were very important in looking at both together and in identifying some of the different approaches and guidelines when doing procedures in the male system. Other than your approach, though, it's pretty much very simple and direct when you're looking at the male reproductive. And so we have here where we're going to be looking from the external to the internal. On the male reproductive system starts from the penis to the testes and within the testicular epididymis, the tunica vaginalis, the scrotum, vas deferens, spermatic cord, and seminal vesicles. You do have some of these in a definition, and the prostate. Some of these are shown on page 360 in a really great diagram. So if you ever get lost on where you're at or what you're looking at, you can come here. As with most of our surgical section, by now we can see that this is identified by different terms such as incisions, destructions, excisions, introduction or injections type procedures, repairs, and manipulations. And so depending on exactly what you're doing and where you're at will identify the different section that you're in. I do want to point out to you that in this section you want to pay special attention to procedures that can be bilateral, and make sure you use either a left, right, or bilateral modifier to identify which side of the body is being done to. In a procedure where you're going in through the body, through the urethra, there are going to be times where you cannot use those bilateral procedure codes. And so make sure to pay attention to those. When you're looking at terminology in the male reproductive system, it's going to be pretty strong. Both male and female, in fact, have a lot of medical terminology used in order to identify the type of procedure that will not only give you what they're doing, but also the details of the procedure itself. You may find some of these terms in your CPT Codebook when you look in your index, but it's important to understand exactly what is it that we're doing to identify that you're in the right section. So make sure you look up all terms that you're not familiar with as you're going through these sections with your coding procedures. At the end of the male reproductive system and before the female system starts, we do have a section on page 367 for reproductive system procedures, which is just a very basic procedure for insertion of needles or catheters in the pelvic organs. And it does not apply to either male or female. And you also have intersex surgery, where a patient goes from male to female or female to male. Note that these are at the end of the male section, but in fact do apply to either or both. Okay, so for the female section, this one's going to be the one where you have the most oomph or the most procedures that you're looking at. We do organize again from the external to the internal, so we start with the vulva and move on into the vagina, cervix, corpus uteri, ovaries, in vitro fertilization has procedures, and the maternity and delivery. Just like with the male systems, a lot of the definitions, a lot of the breakdown of procedures in here are going to be fairly familiar with what you've already seen. And so you want to pay attention to the sections that you're looking at for what we're doing and where we're doing it too. And you should find those codes fairly simple. You do have a couple of definitions for the female genital system, which are found on page 371 at the beginning of or above 56405. which gives us definitions for vulva, perineum, and intra-idius, which is defining the differences of what's included with a vulvectomy as simple, radical, partial, and complete, and the area that that includes. And so they want to give you some definitions on the different breakdowns of levels there. Other than that, you don't have a whole lot of guidelines within the female reproductive system, but when you get over to the maternity section, which begins in my book on page 381, you do have some guidelines for maternity care and delivery. Basically, what they're saying is that you have a couple of codes for each different type of delivery. With that delivery comes a certain level of antepartum and postpartum care. So if you look in here, antepartum care is defined as including initial prenatal history and physical exam, subsequent prenatal history and exams, recordings of weights, blood pressures, so on and so forth, up through 28 weeks gestation, bilateral visits up to 36 weeks of gestation, and weekly visits until delivery. So these are all basic guidelines that all pregnant patients will go by with normal care. Of course, if there's anything extraordinary outside of the normal care, it would be billed separately. And this is where some of the confusion can lie. So let's talk about it for a minute. You have your antepartum care, which can include a number of visits. You have your delivery itself, and your postpartum care, which also includes a specific number of visits. You also have a couple other procedures, such as antepartum and fetal invasive services, where they go in and they're doing some diagnostic procedures to the fetus itself, fetal non-stress tests, and blood sampling of the fetus themselves. When you get into your antepartum and postpartum care, instructions for reporting antepartum and postpartum does indicate here these are services normally provided on an uncomplicated care and delivery. And so you want to keep in mind that if it becomes complicated, some of these will be additional. You have, starting with routine obstetrical care, including antepartum, vaginal delivery, and postpartum care is your first code here. And so you'll notice that it has all three of these if done by the same provider or provider care service. So you have combined codes. Outside of that, your next one, vaginal delivery only, and then vaginal delivery including postpartum care. So you can have a combined code here of just delivery and postpartum combined. The next one being antepartum care only, 4 to 6 visits, or antepartum care 7 or more visits. And so you have 2 separate options for antepartum. And you have postpartum care only. And it doesn't specify how many. So how do you identify the differences? And of course, this was just the vaginal section. They repeat under the cesarean and the delivery after cesarean options. So how do you identify what you're coding will identify how many visits the patient who is pregnant has had with your provider or provider group if you're billing under one name. Now, that information will typically be given to you, and with all of your exercises, if it doesn't say that it's separate, then you should presume that it's not. In the antepartum care, some of the guidelines tell us that if it's less than 4 visits, we're going to code a regular E&M visit. And so for whatever was less than 4 to 6, if she changed doctors or she decided to go elsewhere or needed to be transferred due to complications that maybe your doctor or midwife could not take care of, then our bill will be only for the services that were provided. On the same note, even though there's a combined option for all of the services, some of you may have had children or may know somebody who has, and you may be able to say that it doesn't always fall where you have the same doctor working in the delivery as you saw before your care, or that you even saw the same doctor after. Doctors do take vacations, they do get sick, they do change jobs, they have a number of reasons they may not be available throughout the entire pregnancy. And so for that reason, we have different options. If the same provider provides 4 or more of the antepartum care, the delivery, and the postpartum, if that's your doctor, you're going to bill the correct combined code for all of those services. If the doctor provides less than 4 and nothing else, then you're going to bill the office visit. If, however, they bill just the antepartum care and then the patient went and had the baby delivered by a different doctor who also provided the postpartum care, your doctor will bill for whatever amount of antepartum they did, and the other doctor would bill the delivery and the postpartum, hence the combined option here. Likewise, let's say that your patient saw your doctor for all of their antepartum and postpartum care, but your doctor wasn't available when they delivered. In that case, you would bill the appropriate amount of antepartum care and the postpartum care code, regardless of the number of visits. In those cases, there's a couple of different options, and a lot of times there's different hands in the cooking pot. So make sure that you're reading through documentation carefully to identify how much care did we provide and what should we bill total. Here's another thing to consider. We won't know until after the end of the pregnancy how much of the antepartum care, or if we include the delivery, with our services. So for that reason, it's very important that we identify exactly what is being done by our provider, and insurances know they may not get all of this until the end. That's okay. If she's discharged before the delivery and moves to another doctor, then we would bill for whatever appropriate amount of antepartum care that we have. The other terms that you want to pay attention to, and I'm going to skip the term for abortion for a moment, is the differences in CPT coding for vaginal, cesarean, VBAC, and cesarean after a previous cesarean delivery. So these are the different sections that we split our different care into based off of the type of delivery that the patient has, presuming, of course, that we're involved with that. So after our vaginal deliveries, you'll notice for cesarean deliveries, you have the options for routine obstetric care, including antepartum, cesarean delivery, and postpartum, versus cesarean only, and including postpartum care with cesarean, as well as options to add on for a total hysterectomy after a cesarean delivery. That's important to identify that this is identified for hysterectomy with the maternity section when it's done with the delivery, separate of a regular hysterectomy code. This is basically, this first two sections are your basic vaginal delivery with or without episiotomy and or forceps, means that they can use additional tools to help assist with the vaginal delivery itself, versus the cesarean section where the patient is getting a C-section, and that does not include additional procedures, so you want to identify those separately. You will notice that there's some guidelines here, a coding tip in my book, and I'll read it to you. If you don't have it, make sure that you look it up, that states here, patients who have had a previous cesarean delivery and now present with the expectation of vaginal delivery do have a specific codes, and we're going to talk about those in a moment. If they have had a successful vaginal delivery after a previous cesarean section, or a VBAC, they also have separate codes. If the attempt is unsuccessful and another cesarean section is coded or is carried out, we use codes for a different section, 59618. And so you'll see those under the section for delivery after previous cesarean, and we'll look at that here in another moment. So it's going to be a combined code is what they're saying. You can use vaginal, cesarean, vaginal after cesarean, or cesarean after attempted vaginal. And so it's important to identify those options. There's also codes here for elective cesarean, which are 59510, which is the routine obstetric that we just read. Now, delivery after a previous cesarean delivery. These are for patients who have previously had a cesarean section with the expectation of vaginal delivery, and patients with a successful vaginal delivery after a previous cesarean. So if you come here, you'll see we have routine obstetric care including antepartum, vaginal delivery, and postpartum after previous cesarean. So the only difference is they've added the term that they had a previous cesarean. This is for a patient who is on a second or further pregnancy, and it is complicated and does indicate need for more money to our providers when they've had a previous C-section, because the tissue and the scar tissue does complicate that. Just like before, they're broken up with antepartum by itself for delivery with postpartum care. And then the difference ones, the ones we were just reading on 59618 through 59622, are for patients who had the cesarean delivery following an attempted vaginal delivery after a previous cesarean delivery. And so you'll see those differences there between vaginal delivery, C-section delivery, and vaginal delivery after a previous cesarean delivery versus C-section after a previous C-section. Okay, so, and actually C-section after a C-section with attempted. I don't know if you can read that. Vaginal birth. Okay, and so we want to keep in mind the differences here and pay attention in your reading and your documentation, and make sure you pull up your delivery codes from the right section, include the correct amount of antepartum care and postpartum when it applies. The next thing that we talk about in maternity care is kind of a tabooed term. And so I gave you guys some reading this week that talks about the different types of abortions and what they mean when they're talking about abortion with obstetrical care. So most people think an abortion is simply a term used for an elective surgery in order to end a pregnancy. That's not always the case. In fact, we have different types of abortions listed here, and depending on the type of procedure, the type of abortion we're looking at will depend on the type of code that we get. For example, a missed abortion is considered where fetal death has occurred and there's retained products of care. And I want to give you guys that terminology there because you'll see this in documentation a lot. You have products of care, products of conception, which is what medical documentation will always refer to any kind of fetal growth before the baby is born. Keep in mind this also applies to other products of conception that are subsequent to the baby, such as the placenta that is developed during the growth of the baby and any fetal tissues that may also occur. For the retained POC, retained means that there is dead tissue that is still within the body. And so they'll often use the term RPOC. And then there's another one you'll see occasionally, EPOC, which is ectopic products of care. And so you should know by now that an ectopic pregnancy cannot be viable in most cases. With a missed abortion, there has been death within the first 20 weeks or the first half of the pregnancy. And the products of care have not completely, she's still carrying the products of conception or the fetus that is no longer alive. With a spontaneous, this is also referred to as a complete abortion. This is referring to a miscarriage where there's no additional products of conception left within the body. It all has ejected. It's often happens in the beginning of a pregnancy. You may have a patient who comes in for her antepartum care and has no longer has the baby within her, and so the provider will do testing just to see if they can find the baby. They may do an ultrasound and various other services, but this would be considered a spontaneous. An incomplete is where there's fetal death with some or all of the retained products of care, of conception, sorry. And so this is different from the missed because it's not within the first 20 weeks, and it may include just some of the remaining tissues, such as placental tissues or fetal tissues, but not necessarily the entire fetus. And then you have your septic, which is a previable fetus. So the baby may or may not be still alive, but there's an infection that is causing sepsis to the mom and the baby, and it is considered that the fetus would not be is no longer able to stay within the mom's body, but would not be able to survive on the outside. And so those are the different types of abortion procedures based off of the type of abortion the patient has. These are broken down based off of the different types. You have surgical versus DNC, dilation and curettage, which is where they go in, they dilate the cervix, and they scrape out all of the dead tissue in the case of a missed abortion or induced abortion for these procedures. So you have a couple of different ones in there. Always remember, when you're coding for any kind of procedures like this, it's hard to keep it separate in your head, but it is necessary. So those are one of the challenges that some coders do face with abortion procedures. But always keep in mind that it's not necessarily something that's induced based off of preference. That's all I have for this week. So we've talked about male and female organization within the coding book. Most of them are pretty straightforward and simple to look at. We have a couple of unique situations with maternity and talking about the differences between antepartum and postpartum and delivery, as well as abortion type procedures. If you have any questions this week, feel free to send me an email or a text message if you need something of urgent nature, and have a great week. We'll talk to you next time.